Our first speaker is Dr. Sze-Yuan Ooi, and Dr. Ooi is a procedural cardiologist and will be speaking on TeleClinical Care, a new model of care for the post-COVID era. Thank you, Dr. Ooi.
Thank you, Susan, and thank you very much to the PHN for inviting me to speak tonight. I'd like to tell you about some exciting work that we've been engaged in here at the Prince Wales Hospital and across Southeast Sydney LHD in the remote monitoring space, and that system is called TeleClinical Care. I guess before we talk about the impact of COVID, we should go back to when we first started working on this about 5 years ago now, and particularly to outline the context, which I'm sure you're all familiar with. Even though there have been great advances in cardiovascular research, pharmacology and interventions over the last 3 decades, which have brought down mortality rates, more recently we've seen rising rates in cardiovascular mortality in certain demographics across the world. And that's thought to be driven largely by an aging population and by rising levels of obesity. And also, despite all these advances, we have seen rising hospitalization rates, and there are many epidemiologists predicting that there's a tsunami of cardiovascular disease on the horizon, driven by unprecedented rates of about metabolic syndrome and obesity in children. We live and work in an environment where our hospital occupancy is greater than 100%, and we're about to build an enormous hospital that has 10% reduction in the number of beds that's predicted by the time it opens its doors. And so the question we posed was, could we build a new model of care built around mobile health to try and improve the situation that we're in and deliver care in the community? So our solution is built on a lot of expertise and experience in the telehealth space. The 2 gentlemen that you can see in these 2 pictures on the left are scientist Professor Nigel Lovell, who's head of the Graduate School of Biomedical Engineering at UNSW, and this is Emeritus Professor Branko Sella, who's from the Electrical Engineering Department at UNSW. And so they first built a standalone system, you can see that in front of Branko there, which delivered remote monitoring of physiological data in the home and ran a trial with CSIRO and Telstra, and demonstrated significant improvements in patient outcomes, and also showed that it was cost effective. So it was on the basis of this experience that we built a cardiac solution, but the cardiac solution ran off smartphones rather than a standalone system, which is a lot more cost effective. You can see that we've done this in partnership with many groups, including, importantly, UNSW, Prince Wales Hospital, Southeast Sydney Local Health District, but also partnered with the Heart Foundation, with New South Wales eHealth and the Agency for Clinical Innovation. What we built was a smartphone application that can be downloaded onto a patient's phone, and that's paired via Bluetooth to a set of peripheral devices. And in the cardiac solution, we utilize some weight scales, blood pressure cuff, and a wearable activity monitor for those who don't exercise with the phone in their pocket. You can see this is representative screenshots of the data that the patient can see. The patients were instructed to measure their weight and their blood pressure once a day, and so they could see their own data on the screen, but they were also receiving daily notifications, and there's an example of that on the right-hand screenshot. There were small messages based on the Heart Foundation Managing My Heart Health document to try and promote healthy behavior choices. The third and most important function of the system is that it transmits all of that information back to a clinical backend, which is manned by clinicians in the hospital. And we're able to monitor the physiological parameters coming in from the patients and be able to detect variances in that data. So we also built an alert management system. So at the time of discharge from hospital, patients are prescribed parameters for defining hypertension, hypotension, bradycardia, tachycardia, and weight gain, which is particularly important in heart failure patients. And we prescribed yellow alerts and red alerts, which all come back in an automated fashion from the back end, which has inbuilt data analytic abilities. So that's the system in brief. We trialed that in a pilot study across Prince of Wales Hospital and then later on also at the Sutherland Hospital. We randomized patients who were being discharged from hospital following an acute coronary syndrome or heart failure to receiving usual care or receiving the TCC smartphone app-based model of care. We were hoping to recruit 300 patients, but recruitment was suspended because of COVID-19. But in total, we randomized 164 patients, and the study completed in October last year. You can see that the vast majority of patients, 78%, were acute coronary syndrome patients, 22% had heart failure. And what we were able to demonstrate was firstly that the model significantly reduced readmission rates. So there was a halving of readmission rates at the 6-month mark. We were able to, on the back of that, halve the cardiac bed day stays, which really is the driver of the cost effectiveness model. Interestingly, being enrolled in the TCC program also significantly improved the completion rates of face-to-face cardiac rehabilitation. And we were also able to demonstrate that using the app improved patients' adherence to medications. So you can see at baseline that the medication adherence rates were relatively poor, particularly in the group that was randomized to receive the intervention. But at the end of follow-up, there was a significant improvement in medication adherence rates in those who received the smartphone application, and a reduction in medication adherence rates in those who receive standard care. And even though the study was small, that difference achieved statistical significance. So on the basis of that study, we received a $1.9 million grant from the Ministry of Health, and we're about to embark in the next few weeks on a large randomized controlled trial of this smartphone application across 12 hospitals in the state. In total, the study will recruit 2,500 patients, which will be the largest mobile health study in a cardiac population in the world ever. So we were supposed to start the study last year, but COVID-19 obviously became a global problem. And the team sidestepped during the pandemic to build a monitoring solution for COVID-19 patients in the community. And some of you may well have had patients who were enrolled in our COVID-19 system. So, you know, the important issues during the pandemic were that we would be able to support COVID-19 patients in the community. It was recognized early on that patients can be relatively well at the beginning, but have a significant deterioration in their health somewhere around the 10 to 14 day mark, and that the remote monitoring of oxygen saturation levels, heart rate, and symptoms seem to be really important in terms of detecting clinical deterioration. And that, of course, is really important in terms of deciding who needed to return to hospital for more intensive care. And it was important also that we could build a clinician portal with inbuilt predictive analytics, just in case we had a situation like New York or like Lombardy, where we had potentially thousands or tens of thousands of patients in the community that we had to remote monitor in an easy fashion with minimum resources. So that's what we built. We built an app which is co-designed with our infectious diseases and respiratory colleagues that delivered a questionnaire to patients with COVID-19 who were quarantined in the community to ask them about their symptoms twice a day. We were able to provide them with a low-cost oximeter so they could measure their pulse rate and their oxygen saturations at home twice a day and input that data, and then we were monitoring all that data coming in from the back end. It also delivered daily educational messages reminding them about the importance of quarantining, hand hygiene, as well as information about COVID-19 and its potential effects, and it offered links to government websites giving updates on the COVID-19 situation. We developed a completely hands-off referral workflow because of our concerns about our staff becoming infected if they were in contact with the patient. So there's a completely hands-off way of consenting patients, delivering the oximeter, training them over telehealth to download the app onto their phone, to pair it with the Bluetooth oximeter, to measure their parameters every day, and also to notify them if there were any alerts that were triggered to make some decisions about whether they come back into hospital. So that was all entirely hands-off, which in itself, from a trial point of view, was innovative and novel. Also, in the context of COVID, we developed a heart failure app. The original pilot study for the cardiac patients was for patients being discharged from hospital after an acute admission, whereas this app was for heart failure patients who were being looked after in the community by our heart failure outreach program. And the rationale for that was they're extremely vulnerable population and at high risk of developing critical disease should they develop COVID. So that's actually projected to start next week. We were also successful in getting a $1.7 million federal grant to run a similar type of model of care, but in stroke patients, and that's due to start midway through this year. And we are working closely with South East Sydney Local Health District, with New South Wales eHealth and New South Wales Health to deliver a suite of other smartphone app solutions based on our ecosystem, but for other clinical cohorts, including COPD patients, gestational diabetes, the geriatric flying squad to support the aged care population in the nursing home and in mental health. We've been working with Webster Care to build a medication adherence monitor. We've developed an exercise program to deliver a unsupervised digital graduated exercise program in the home for cardiac rehabilitation and pulmonary rehabilitation purposes. And we're working closely with eHealth to integrate our backend with Cerner, which is the hospital electronic medical record system, and MyVC, so that we can instantly, with a touch of a button, use telehealth to contact patients when an alert is generated. And the whole idea eventually is that we will have one app that will have multiple modules and functionalities, and we can prescribe the app for a particular patient, because as you know, patients don't come as a cardiac patient or as just a stroke patient or a mental health patient. Patients are a lot more complicated than that, and often come with multi-organ issues. So to be able to prescribe an app that's appropriate for your patient to be delivered at the time of discharge from hospital, to support them in that transition from hospital acute care back into the community. And finally, this is all in the context of some major redevelopments that are happening across the UNSW Prince of Wales Hospital precinct. The Tyree Foundation recently donated $10 million to help set up the Institute of Health Engineering, which will be steered by Professor Nigel Lovell. And the whole idea is to bring the faculties of medicine and the faculties of biomedical engineering closer together. So instead of the engineers building interesting and innovative technology and then looking for a health solution, that will be reversed. So clinicians, hospital executives, patients will help identify areas of need, and we'll be working closely with engineers to engineer solutions to those problems. So this is a look at what Prince of Wales Hospital precinct will look like in 2022 and beyond. So this is the acute services building that's currently being built. And at the back of it, which you can't see in this picture, there's another building which is actually on the inside, contiguous with the acute services building. and that is the Institute of Health Engineering. So Prince of Wales Hospital will be a hotbed of patients, executives, clinicians, engineers, industry, all working side by side, building biotechnical solutions for the future. And the first pillar of the Institute of Health Engineering is connected health, of which TCC will be the first project that comes off the ranks. I might stop there and see if there are any questions. Yes, at the moment this is at the public hospital, though obviously it could be deployed anywhere. It's a public hospital or private hospital. It's agnostic to the healthcare setting. I should also say that we are meeting with the PHN to discuss trying to integrate our back end with medical director best practice to try and build a truly integrative system so that information can flow backwards and forwards between the hospital team, between the patient and the remote monitoring data, and also the GP. Could it be deployed if there's a resurgence of the pandemic? Yeah, well, it doesn't need to be redeployed. It's already deployed and it's sitting there quiescent. We're still having small numbers of COVID patients on the system, largely from hotel quarantine, from returning travellers. So the system's still in place, yes, and ready to be escalated if need be. Hopefully that won't be necessary. Replace current cardiac rehabilitation programs. Great question, and I get asked that a lot. So absolutely not. The idea, or the way that we have designed and engineered the solution is that it be additive to current resources. So a good example of that, and I showed some data for cardiac rehabilitation, was that the system actually improved cardiac rehabilitation completion rates. And as you know, I think that question came from Penny. Penny will know that globally the uptake of cardiac rehabilitation is poor, even though it's a really well-proven intervention in terms of reducing secondary cardiovascular events. And the reason for that is a multitude, right? It's part of it is belief systems or logistic things like being able to get to the hospital or having to work and being able to find the time, or anxiety about exercising in groups. Lots of reasons. So it's interesting that we were able to improve cardiac rehabilitation completion rates, and I think that's partly because the app empowers and engages patients. Hopefully, the idea of embedding a exercise program into the solution is not to replace what happens in the face-to-face cardiac rehabilitation, but to sort of reinforce and allow patients to feel supported when they're exercising at home in between sessions. So absolutely not. It won't replace cardiac rehabilitation programs and shouldn't. Kinga has asked how GPs get involved. So during the trial, we did notify any GPs whose patients were recruited in the trial to contact us if they wanted to have access to the patient data. And the patient data is really quite comprehensive, you know, because you have all that data coming in on a daily basis, and we can see it in the back end. And GPs were allowed the opportunity to access that for their patients. It requires a secure sign-in, and so you have to go through a registration process, which is pretty straightforward. And then you can sign in and look at your own patient's data when you see them. But we're working on hopefully a more integrated solution so that we can message GPs on a regular basis with just a summary statement of the patient's data over the last 1 month or 3 months, and notify you of any alerts. And also to be able to push things through to your electronic systems in your practice, which I guess is the holy grail, to be able to have sort of two-way communication. So we know if there's been changes in your medications, for example, then our back end gets informed. But as you know, system interoperability is always the problem and the, I guess, the solution that we all are looking for. And we'll be hopefully working closely with the PHN and with Southeast Sydney LHD to try and build that solution. But that's, that will take some time. Just looking at the questions. Who will contact the patients when there's an alert? So the remote monitoring team at Prince Wales Hospital are tasked with looking at all the alerts as they come in, contacting patients to validate those alerts, and if need be, escalating that to the relevant people, whether that be the cardiologist or the heart failure nurse or the GP. So you'll be contacted directly, usually by telephone, by our team, telling you of any deterioration in your patient's care that requires attention. At the moment, sorry, just looking at the question about smartphone technology. Yes, so at the moment, the way that we ran the trials was very pragmatic. So you needed to have a smartphone to be part of it. And we did look in our screening logs at the number of patients or the proportion of patients who weren't eligible because of lack of access to smartphone technology. And it's a real problem, particularly in designing our large trial. We've gone for a pragmatic approach, recognizing that it's unlikely that New South Wales Health will buy everyone a mobile phone. But it does create or maybe amplify this disparity in healthcare, because patients who can't afford it are probably those at greatest need. We have been able to access some iPads, which were granted by New South Wales eHealth. So there will be a proportion of patients that we will be able to onboard onto the system, loaning them an iPad for 6 months after discharge. But it's also I guess the other limitation is cognition and patients' ability to use the technology, which is a little bit hampered in the elderly population, though there is also the ability for family members or carers at home to be able to assist the patients in using this technology, and in that way, perhaps we can improve delivery to those who otherwise would not be able to access the technology or use the technology.
Can My Health be integrated with this?
Yeah, so that's the, I presume by My Health you mean My Health Record, Kinga?
Yes.
And that's absolutely the plan, that it'll be able to write to My Health Record. But as you know, My Health Record, it stores things at the moment in PDF form, which isn't particularly useful for data mining or just for sharing discrete data sets. And so what we're trying to build is a solution that's far more complicated and complex but sophisticated than just writing to My Health Record. But it will also write to My Health Record, so that there's a permanent record of what we're measuring and what actions are taken when an alert is generated in that. Hui's asked about age range, so adults, so anyone above the age of 18. We are actually working with, and the Children's Network are looking for a virtual care solution for children. We haven't been actively involved in that at this stage, though. We are on the tender list for the state for delivering virtual care solutions to anyone across the state. But at the moment, we haven't had much traction in the pediatric space. But it's a little bit difficult because they obviously need a different set of peripherals that are that have regulatory approval for use in small people.
Okay, we've got 2 minutes left. If there's any last questions.
Just checking I've answered all of them.
They
came in a flurry.
They did come in a flurry. It's all or nothing. Do we get the weight? Who will contact patients when there is alert reading, such as elevated BP?
Yeah, so that's the team at Prince Wales Hospital. So the Prince Wales Hospital, in a hurry, we built a remote monitoring team during COVID because there was an immediate need. The solution beyond that, when we build the new acute services building, there is in the architectural and strategic plans already plans for a virtual care centre. And that virtual care centre will do a multitude of different functionalities, but one of the functionalities is remote monitoring for the entire LHD. So we'll be monitoring patients across our catchment area, as well as St George and Sutherland Hospital. So quite a large catchment area.
Well, thank you very much, Dr. Ooi. I think we've come to the end of our time, and even someone has thanked you in the questions. So that's
Thanks,
very nice.
Thanks, Susan.
So thank you very much
You're
for
welcome.
giving us your time tonight.
Cheers.
Okay, bye-bye. So our next speaker is Dr. Hugh Wolfenden. He is a specialist adult and minimal access cardiothoracic surgeon and will be speaking on minimal access cardiac surgery, more than one way to fix the aortic valve and coronary artery. Thank you, Dr. Wolfenden.
Well, hopefully we're on there. Yes. Evening, everybody. Thanks to Susan and Colette for asking me to talk tonight. They did ask me to talk on, you know, how COVID's changed everything or anything in cardiac surgery, and I think probably all of society, we've been the least changed, the least affected with COVID, because it hasn't really affected our surgery. We've just kept operating. So the best I can do tonight is do a Cook's tour, seeing we can't do any other tours. We might as well do a Cook's tour of cardiac surgery and what's sort of relatively new in the realm of cardiac surgery and what's benefiting our patients. So 3 areas I wanted to cover were those of the MIDCAB, or minimally invasive direct coronary artery bypass grafting, aortic valve replacement via a minimal incision, and some atrial fibrillation, both in surgery, that is, in combination with combined surgery for other things like valves and coronaries, or even just as a standalone. Now we start with coronary disease itself. The data that shows what benefits survival in patients with coronary artery disease is really related to how much disease you have, and the greatest benefit has been shown to be with coronary artery surgery, particularly when you've got triple vessel disease or double vessel disease with proximal LAD disease or left main. In other words, where there's a lot of myocardium at risk, and that's where surgeries are clearly shown to improve survival. Different when it comes to symptoms. If they've got symptoms, either angioplasty, surgery, or even occasionally medical therapy, but usually angioplasty or surgery is necessary to manage those symptoms. So it is a spectrum. It's very important always to remember that maximum medical therapy is the basis for everything to start with. So antiplatelet therapy with aspirin or Plavix, cholesterol management, and obviously the other risk factors of diabetes, hypertension, smoking also need to be done, no matter what other therapies you do. Of course, there's classic surgery, coronary artery surgery, which started back in the late 60s. It's been going ever since. PCI, angioplasty, which has evolved from through the 80s, but mainly in the 90s. And then what I want to talk about more today is classic surgery, but doing it through a small hole. Now, the bottom middle there has got a stenotomy type incision. What I'm talking about is a left anterior small thoracotomy, which is called a LAST, which is a sub-mammary incision through the fourth intercostal space. We do this to avoid the effects of a stenotomy, avoid reducing trauma, allow for shorter length of stay. Cosmesis is a secondary effect, but it does allow them to get back to work much quicker. And it has been shown you can do this procedure with just as good results as far as patency of the mammary artery to the LAD, and I'll show some of those in a while. Now, this is what I call a classic MIDCAB as opposed to a robotic one, which I'll also show. And you harvest the mammary artery through that incision with that retract you can see on the top right, which lets you view underneath. And hopefully my mouse is showing this is the top part of the mammary that you're viewing through this hole as you mobilize. And probably the greatest benefit of this incision over doing things through a stenotomy is the fact that you can use local anesthetic. And that's the bottom left view. You can see there's just a needle showing in the top right of that picture. That's local anesthetic going into the intercostal space. And because you can do that over about 8 spaces, you can make the whole of the chest wall numb from local anaesthetic, which allows you to extubate them very readily compared to a stenotomy. Now, this is what you end up doing. You have a retractor and a stabilising system, and the bit within that little rectangular stabiliser stays still, and those white elastic loops lift up the coronary artery, which in this case is the left anterior descending, and keeps that still. The rest of the heart goes on its merry way, and the bottom right you can see a shunt within the actual LAD itself, and the bottom middle is after you've done the anastomosis. And when you're finished, that's what it looks like. It's a fairly small neat incision which heals well in that line. Now, robotics have come along and helped us a bit. This picture shows the 3 black ports on the lower part. That's for harvesting the mammary. There's a few other ports they've got there for using anastomotic devices that we don't have in this country yet. But the robot itself has allowed us to get a longer length of mammary artery to use. That allows us to do sequential grafting. But mainly it's allowed us to do larger patients, because as you get much over 90 kilograms, the fat pad behind the chest in front of the left ventricle gets quite bulky and makes it very hard to do what I call a classic MIDCAB. Whereas using the robot, you use CO2 to insufflate the chest and push all that out of the way. It also has a certain amount of a sex appeal with the robot. It's very trendy and nice to use. This is actually a video from a colleague of mine, Dr. Basson. This is at double speed, in case you're thinking we really work at this pace. But that certainly has allowed us to do a lot more sort of cases. And this is what we want to do. This is an angiogram of the mammary artery coming off the subclavian, supplying left anterior descending. The mammary artery is a privileged vessel. It does not get atheroma, so it does not block up. If it's working after a week or two, it's almost certainly going to work forever. The type of patients we get to do it on, ideally are those with isolated proximal LAD disease, so they tend to be younger. Occasionally those with some moderate left main disease, which are the angioplasty people like to avoid a bit because they can cause trauma to that, and it can cause some problems later on. Occasionally we do hybrid procedures, which is where we do the MIDCAB first, and then non-critical lesions in the circumflexing right coronary are stented. And occasionally patients need surgery and they're not suitable for a stenotomy. Been doing this for a long time. We're almost up to 300 cases now, having started 24 years ago. Done lots of research on it and presented a fair bit on this over the years. It's a very good procedure. Only lost one patient very early in the series, but otherwise I've done very well. Initially we did lots of them. Faded away a bit when stent mania, as I call it, came out, but now there's a little bit of a swing back as the benefits of the mammary artery are well known now. The bottom right just shows occasionally the mammary gets damaged and you have to convert to a stenotomy, but thankfully it's very rare. And this is the sales pitch that we like to put. The right-hand slide's got a mammary artery graph there. Left-hand slide shows in-stent stenosis, which does occur occasionally. The benefit of the mammary, as mentioned, is it doesn't get atherosclerosis in it. It continues to supply the downstream vessel with numerous factors, including things like nitric oxide, which is actually protective of the distal vessel, which is something you will never get with a stent, because the stent is still a diseased vessel that supplies the downstream vessel, so it's not as protective as the mammary artery graft is. So that's the MIDCAB procedure. Before we move on to the second type of surgery I want to cover, and that's for aortic stenosis, which is a major disease of our society, our aging society. And that can be handled in lots of ways, but medical therapy, as you may realise, is very limited with that right-hand slide. I'm sorry the numbers dropped off the bottom and sides of it, but basically with time, symptoms come and then they die soon after they get symptoms. So About 50% of people die within 2 years of developing symptoms from aortic stenosis, so medical therapy is rather limited. The other therapies are the ones I want to deal with. PTAV is balloon dilatation of the valve, which we do occasionally to palliate if the patients need something else more urgently done, or sometimes it's useful diagnostically to tell if the valve is actually the cause of that problem, as opposed to them being overweight, their lungs being bad, or numerous other reasons that people may be short of breath. Now, TAVI is the newer one that I'm sure you've seen lots of news about, and there's like 2 TAVI valves on the bottom of the screen. The core valve, now called the Evolute, which is a self-expanding valve, and then the Sze-Yuan valve is the other one there being implanted. That's a balloon expandable valve, and you can see that patient has had previous surgery. So that's the TAVI valve, which we use for older patients who are at higher risk for surgery. SAVR is the way we now call aortic valve replacement. That's surgical aortic valve replacement. But what I want to cover is doing the aortic valve replacement, but doing it through a less invasive approach. And this is what we call a RAST incision, or right anterior small thoracotomy. Some people call it a RAT, R-A-T. And this is the view you get of the aorta with, you see a bit of the right atrial appendage there, but you look straight down at the valve. Now, why do it? The stenotomy is the gold standard. Great access. At the bottom on the right here, you can see a stenotomy. This is actually a coronary patient, so it's a slightly longer incision, but still a lot of exposure, easy to cannulate, very familiar, easy to teach, but the sternum has to heal, so there's 6 weeks plus of healing, not being able to drive, not being able to lie on your side. Some people do it by only cutting halfway down the sternum, but that's just as painful, if not more. The right anterior approach is far less discomfort. They've got full power on the left side. They can drive a car at 3 and 4 weeks. And you don't need the whole incision that you can see there. The yellow square there shows you the only part that you actually need to see. So there's a lot of redundancy in that incision. And this is how we do it. Second intercostal space on the right. And that's the view you have of the aorta. And that's the view you have of the valve. It's actually quite close, very close to the chest wall there, which is why I call this one the easiest of the mini approaches, because everything's so close. And these are some of the valves we use. On the right, this is a bovine pericardial valve. On the left, the same sort of valve, but this is actually a Percival valve. This is actually on a frame. This is actually a hybrid type valve. It's a TAVI type of valve, but never made the TAVI market because they didn't want to make it small enough to collapse to go up through the femoral artery. So they made it in between. So it's a very rapid deployment valve with no sutures needed. And this is the result, very cosmetic. Patients really do surprisingly well from this. They go home a day or 2 earlier. You can do other procedures through it, including the picture on the right there. That's an atrial clip, which is 2 metal bars with a spring between them that squashes the atrial appendage. So for patients who've got atrial fibrillation, which we'll talk about soon, it's a handy device to use at the same time. So this is sort of a routine approach now for doing aortic valve replacements in isolation. And so far, excellent results that help the patient get going much quicker. Now, the last bit I want to go through was atrial fibrillation, and that is atrial fibrillation. ECG on the bottom right. Everyone's used to seeing ECGs. It's quite interesting in the operating theatre. Whenever you ask people what rhythm the patient's in, they all look up at the monitor, when it's actually a lot easier to tell what rhythm a patient's in by looking at the heart. And that's the right atrial appendage fibrillating there next to the aorta. Now, atrial fibrillation you'll be very much aware of, major disease or aging society. What are the aims of treating it? Clearly you want to improve symptoms in many people. That's classically with paroxysmal patients, because when they flip between sinus rhythm and atrial fibrillation, that tends to knock out the atrial effect, loading their ventricle, and they get symptoms. They tend to lose that sudden change when they become chronic, and a lot of chronic patients don't even know they're in atrial fibrillation. Some do, particularly if they get slow or fast, and that may need to be treated for those reasons, which I'll talk about in a second. The main reason we need to treat atrial fibrillation, of course, is because of the risk of stroke from clots forming within the left atrial appendage particularly, but also elsewhere in the heart, that then embolize to the brain with catastrophic results. And people have tried to look at which is the best way to manage it, whether to control the rhythm by cardioverting them chemically or electrically, or whether just to control the rate. So the rate's not too fast or too slow, versus the appendage, versus, of course, the need for anticoagulation. And those risks you work out using the JADSVAS score that I'm sure you're all aware of, and balance that with the risk of bleeding with the HAS-BLED score, which is the balancing acts that cardiologists and also general practitioners have to go through with their patients to keep them away from strokes, preferably, and also away from the awful effects of some of the bleeds that also can occur. I won't get into a discourse on warfarin versus NOACs, but I'll go more into how to fix it up. Now, as mentioned, medical therapy, rate versus rhythm, anticoagulation always. There are methods of treating the atrial fibrillation other than cardioversion, and there's some catheter-based ones that have followed on from the surgical procedures that I'll get into in a second. Surgical correction, or just doing the appendage, and there's a couple of ways of doing that I'll mention shortly. And of course, if you get complications of rate, so if they're too slow, a pacemaker, or if they're too fast and you can't control them, an AV node ablation and a pacemaker, because they become pacemaker dependent. But personally, I'd rather try and get them back into sinus rhythm, which I think is the way the heart was designed and the way it should be best managed. Now, Jim Cox in St. Louis developed a surgical procedure back in the 80s. Essentially, the concept is atrial fibrillation is where the electrical current runs around in circles in the atria. If you've only got one circle running around, you'll get flutter. And if it's around the tricuspid, that'll be classic. If it's around somewhere else, it'll be a non-classical or atypical flutter. If you get more than one circle, you'll have a coarser AF, and if you get lots of them, you get a finer AF. So it's just a matter of how many circles are running around as to what the AF is. Now, to prevent that, what he did was cut up the atria and then resewed it such that it made a maze. So there's only one pathway between the SA node and the AV node that the current can go. There are lots of blind paths, but there was nowhere it could go in a circle. And it needs about a 6 centimeter circle to be able to do that. So this procedure he developed and worked incredibly well, but it's quite a complex operation to do with high risks of bleeding. So they worked out ways of doing the same thing to create this scar line, a line of electrical block, using radio frequency initially and then cryotherapy. They tried a few other ones, but they didn't work that well. Top right, you can see a cryoprobe in action. The bottom middle is a bipolar RF, where the current goes between the two electrodes, and that's very good at creating a full thickness lesion, which isn't very broad, which is nice. The bottom right's the monopolar RF probe, which we tend to not use as much now because the cryoprobe is better for doing that. Now, we've been doing this for a long time, over 20 years, with patients having mitral surgery and having atrial fibrillation, and it's very good for that. Get about, for chronic fibrillators, you get about 80 to 90% cure rate. For things such as doing with aortic valve or coronary surgery, the data's not as clear cut, but you certainly get better results too, because they usually don't have as much derangement of their atria. It's been done for a long time, and there's mixed results, but certainly the harder you try, the better the results you get. There's been simple procedures where they just reduce the size of the left atrium, but that doesn't work as well as doing the full maze procedure. Quite often you need to put pacemakers in these people, because quite often they've been in atrial fibrillation for many years and their sinus node just does not exist anymore. Now, I do it because your patients thank you a lot. If you can get them into sinus rhythm long term, they feel better and they are very happy to get off anticoagulants. It doesn't add anything mortality, morbidity-wise to the operation. And now that we've got the benefit of both the bipolar and the cryoprobe to do surgery with at the same time, the results are vastly better too. There's also minimally invasive techniques which we now can use. As mentioned, getting off anticoagulants is great. Up to almost 500 now, and certainly with paroxysmal cases, it's very rare for one of them not to stay in sinus. 80 to 90% for the chronics. Now, what I like to do occasionally, which we don't get to see a lot of, because the cardiologists still seem to manage most of them, is doing atrial fibrillation surgery for those who've just got atrial fibrillation alone. There's not great scientific data on this because there's not a lot of cases done. It doesn't mean it doesn't work, it just means there's not a lot of results to utilise. But it can be done quite readily through a very small hole. There's a couple of different techniques. I like to do it just through a little mini right thoracotomy, just like you'd use for doing a mini mitral. And that allows you to do a full maze procedure. Works very well. The other bit that goes with it, and the bit that you can do with surgery that you can't do with catheter-based techniques or medical therapy, is you can deal with the appendage, which I believe is the critical thing to do when you're doing atrial fibrillation surgery because of the occasional failure of AF surgery. And of course, the last thing you want them to do is be having strokes. And often the removal of the appendage is the single greatest thing you can do. And this is just showing the atrial clip. There's the bottom one's the minimal access and the top one's the open one, which occludes the base of the left atrial appendage from the outside. It's very effective, very safe. We can use a stapler, which I'll show on the next slide. And of course, you're probably familiar with the Watchman, which is the catheter-based approach to doing it from inside, which has its own limitations. Oh, sorry, this bit's playing up on my slide. I'm not sure it's playing up over there too, mine's just changed, but that's an appendage that's been resected. And it was meant to play, but as I'm not on my home computer, it doesn't want to play on my office one. That's the resected appendage, which stops fibrillating as soon as you resect it. And if you touch it, it'll contract for the next 10 minutes. And this is the inside of the left atrial appendage, just to show you the trabeculation. And that's where you get your clots forming. And that's why it's so dangerous compared to, you can see the smooth bit around it, which is the normal left atrial wall. And the bottom right is where it's being closed with a stapler in that case. That is the critical bit in doing AF surgery, is to get rid of the appendage, which we can do as a standalone procedure. And this is the aim. This is sinus rhythm, that lovely rocking motion that we aim for with surgery. Anyway, I'll leave that there for this Cook's tour of 3 operations that I like to do, and I'll leave it open to questions.
Thank you, Dr. Wolfenden. That was great. So we do have some questions for you. Does it take longer than conventional surgery and longer duration of anaesthetic and its complications?
Minimal access surgery does take a bit longer. Now, to give you an impression, for a MIDCAB, it takes me 2 hours skin to skin. If I did that through a stenotomy, it would take me about an hour and a half. But the patient gets extubated MIDCAB gets extubated on the table, whereas a stenotomy won't be extubated for 6 to 10 hours. And that patient from MIDCAB goes home 2 days quicker than an on-pump and a day quicker than an off-pump stenotomy case. Mini AVR will go home 2 days quicker than a stenotomy AVR, but the standard mini AVR will take me 3.5 compared to 2.5 hours. So it takes you a bit longer, but it's just a bit more fiddly. And AF surgery just adds about 20 to 30 minutes to a routine type mitral or aortic valve case. That's the stenotomy approach. Doing it as an isolated procedure, well, it doesn't have a comparative, it takes about 2 to 3 hours. And they're extubated fairly quickly. Hope that makes sense. And next one.
Can anyone needing a bypass?
Cabs are very selective because they need to be to people with LAD disease. that's appropriate. Now, patients who've got lots of calcium down their LAD are not a good candidate, and those who've got an intramyocardial LAD are not a good candidate. That's sort of a subset. And then it's up to how important and how you can fix up their other vessels if they've got multi-vessel disease. So if they've got significant circumflex and right coronary disease, is it appropriate to do that with a stent? In which case, then you do a hybrid procedure. If it's not, or if it's very tight proximal disease, they're actually probably better with bilateral mammary just grafted on using a stenotomy approach, which will give them the best long-term result after 10 years. So it's a young patient with proximal triple vessel disease. So it's all sort of a horses for courses. But certainly if they've got isolated LAD disease, it is the candidate that's perfect for a MIDCAB procedure.
Okay, the next question we have, does this mean traditional CABG will be a thing of the past and new techniques can make new trainees not capable of doing open CABG if needed? No,
unfortunately, for the reasons I just mentioned, most of our patients now are older with diffuse triple vessel disease by the time they get sent to us. So they're all requiring multi-vessel grafting. So they're all that triple vessel disease category and not always ideal for a MIDCAB approach. Some of them, as just mentioned, are okay for a hybrid approach. So there is it's big spectrum. So it's never going to be just, oh, you can do MIDCAB on everybody type thing. That won't happen.
The next question, what are selection criteria for maze operations for patients with AF?
Anybody with AF who's having cardiac surgery is essentially suitable. It's really up to the surgeon and their familiarity with the techniques, and most surgeons should be fairly familiar with doing it. Cardiologists aren't always as keen or agreeable with us doing it because they just tend to leave them in AF and just manage them with anticoagulants. They're not as aggressive in the management as we tend to be. But most people with AF undergoing cardiac surgery for other reasons are suitable. As far as those suitable for a standalone AF surgery, probably most of them are as well. You really have to look at your patient and say, what am I going to do for you with what I'm managing you with your AF surgery? So if they're young and you're looking at a sort of a 40-year-old that may have another 40 plus years of life that they're going to be on an anticoagulant for, with the risks that are involved with that, it may be better to fix them up instead of just putting them on a NOAC and just looking at them once a year. Atrial fibrillation is a nasty condition. The patients that are younger and healthier may be at lower risks of strokes at that age, but the net effect after years is quite significant. What happens is, and I see them later on, usually in their 70s and 80s, when their left and right atria are very dilated from being in chronic atrial fibrillation, that dilates the tricuspid and mitral annulus significantly, and they both start to leak a lot. And then they come to surgery for that. Some patients, the AF causes a significant ventricular cardiomyopathy, often due to a fast rate, but even with a controlled rate, they can still get that cardiomyopathy. So they can get significant damage to their cardiac function that is avoided by getting them back into sinus rhythm. So if someone's just gone into AF for the first time in their 80s, a lot of people take a more simple approach and just manage them with anticoagulation and medical therapy to control their rate. But certainly the longer they're likely to be in AF, as in alive in AF, I think the more aggressive you should be at trying to get them back into sinus rhythm because of the cumulative risk of AF, the cumulative risk of anticoagulation, and the benefits from getting them back into sinus rhythm.
I have two further questions relating to maze. Can maze surgery be done as prophylactic with any cardiac surgery? And patients with HOCM and AF, can they have maze surgery?
Yeah, now, that's a nasty group of people. Certainly, maze, you wouldn't do a maze prophylactically. I do a limited procedure prophylactically in people who've had one episode. So the main triggers, particularly for people with left-sided conditions such as mitral and aortic valve, most of the triggers come from the pulmonary veins. Now that can start AF in paroxysmal. Once you're in AF, you don't need the pulmonary veins to start the AF because it's self-perpetuating. So people have had one episode, I'll do a left-sided maze. I won't do the right-sided component, but I'll do the left side. And people have had chronic AF, I'll do biatrial maze, so full maze. Now, those with HOCM are those, and also it's very similar to those with long-standing hypertension and diastolic dysfunction, and also with those with aortic stenosis. They've got a very thickened left ventricular muscle, which means the filling pressure of the LV is quite high, which puts that back pressure onto the left atrium. Left atrium stretches up and they get AF. Now, with a stiff ventricle, if you go into AF, that really knocks your cardiac output down. So certainly those with HOCM who I do a septal myectomy on, they have their appendage taken away because they have a risk of AF later on. If they've had any atrial arrhythmias, we do a maze procedure on them at the same time. So yes, we just certainly do like to do that in those subgroups if we're operating for the HOCM. Yep.
Looks like that's all of the questions now, and we've just a few minutes over time, so I think we've done well. So thank you very much, Dr. Wolfenden, for your time. And our next speaker is Penny Hough, and Penny is an accredited exercise physiologist and will be speaking on rehab guidelines for GPs.
All right. Hello, everybody. My name's Penny, and I'm an accredited exercise physiologist at the Hills Private Rehab Hospital and have been there for the last 9 years. And cardiac rehab is my passion. Before I was working there, I was a cardiac stress tester in a cardiac clinic. First things first, can everybody please stand up because you've been sitting for far too long? I'd love you to be standing while you listen to my talk so that we're not sitting and having those negative effects of sitting for too long. So as I said, I'll be talking about just the benefits of cardiac rehab, as well as what's involved in cardiac rehab so that you know for your patients what's involved, what they can expect, and how we can try and provide our patients with the best possible resources to be able to help manage their own health conditions. This is an extremely important aspect of cardiac rehab, that education side, because as we know, heart disease is the leading cause of death in Australia. And 115 Australians per day die due to cardiovascular disease. And pretty much all of the patients that I look after, they didn't know that they had any sort of heart condition. They didn't know that they were at risk for any sort of heart condition. And so being told by their GP that something is wrong with their heart and that they need to go and see a cardiologist, and the cardiologist tell them that they need to go and have surgery immediately, that scares a lot of these patients, and they have to try and cope with what they've been through after they've already been through it. And for a lot of them, they feel like they can't do anything, or they can't get back to doing their normal daily activities because they're too scared that something's going to go wrong and might inevitably kill them. So this is extremely well documented, and we can see that we know that 1 in 2 people that that have a heart attack don't end up returning back to work. And 1 in 4 don't return back to their normal work capacity, and 1 in 4 people don't return to work at all. And this doesn't need to be the case, because with the proper rehabilitation, education and guidance, we can get these patients back to their normal daily activities and back to living a normal life, which is where cardiac rehab is so important. It is basically using a multidisciplinary approach to provide the patients with as much guidance, support, knowledge and education to help them manage their own health conditions. So in our rehab program, we do education sessions every single time that they come in. And it's presented by not only me as an exercise physiologist, talking to them about what are their risk factors for cardiovascular disease and how can they minimize them, and what exercise is best, but also cardiac specialists talking about the surgery that they've been through and what implication that has on how their body is functioning. The dietitians to give them education on healthy heart eating and the simple changes that they can make in their normal cooking activities to make their food heart healthy, as well as the psychologist who helps to guide the patients through all of the emotions that come with having a heart condition, with depression being one of the biggest ones. And all of these things put together with the exercise intervention that we provide helps patients be able to take control of their health and their health condition, to promote good lifestyle changes, because it's not just 6 weeks of doing a certain type of exercise that we're looking to achieve. We're looking to teach them that it's good lifestyle choices that will help them get back to normal daily life, but also help minimize their risk of another cardiac event. And all of these things help to improve not only their quality of life, but to help restore their confidence in their ability and to minimize the occurrence of another cardiac event. So just as a quick summary for you, there are 3 phases of cardiac rehab. Phase 1 is immediately post-op, the first 4 weeks post-op. And the goal of this phase is to, first of all, deter the negative effects of bed rest. So the longer we're not moving, the more our body deconditions. So we want to try and get these people up and moving around in a nice, gentle way, so that they can try and regain their functional capacity. And that's just done by simple things like walking, increasing the amount of time that they're able to walk for, and just some gentle range of motion exercises so that they can do simple things like getting up and out of chairs, getting up and out of bed. Phase 2 is in the outpatient program in the 4 to 12 week post-op. And it's looking to build upon the benefits that we've already achieved in phase 1. So building upon the strength and conditioning that we've managed to build in that early phase, trying to get them into some gentle household activities, as well as starting to introduce the education sessions that start to show them what are some better lifestyle choices that they could be making to help minimize their risk factors that put them at a high risk of having another cardiac event. And in phase 3, it's from 12 weeks indefinitely. So hopefully by this phase of the program, patients are generally feeling much better in themselves than what they were obviously immediately post-op, but also prior to having their surgery, because a lot of patients will say to me, I didn't realize that I was actually getting really short of breath when I was walking upstairs, but now that I'm doing it and not feeling that, I can see how bad I actually was, but because it was such a sudden onset, I didn't realize that it was such a big deal or that it was such a big problem. So the phase 3 is trying to really reinstill the idea that these are lifestyle changes that we're looking to make, and we're trying to get they should be getting back into their work, even if it's on reduced duties, looking to build to normal duties, as well as getting back to all of their daily activities, physical activity, and their normal exercise routines. And this is just an example for you of what our program looks like at the Hills Private Hospital. So as you can see, phase 1 is in the hospital. It's very gentle, and the exercises will depend a lot on any restrictions that they might have, which I'll talk about in a moment. Phase 2 is where we bring in the education, and phase 3 has it as well, where we're providing 1-hour education sessions and then getting them in and exercising, teaching them what their body can actually do, knowing that we're monitoring their blood pressure, their heart rate, their breathing response to the exercises, and showing them that if you can do this here and you can see how hard you're working or how hard what your breathing rate is doing, and trying to relate that to, now what can you be doing at home that is similar to this? Or you've probably been able to do things that are a lot gentler than this, but you've not been able to, whether it's through your own nervousness of getting back to it, or your family's nervousness of letting you get back to it, which is often a big thing for people. So the benefits of cardiac rehab are really well researched and well documented. And Dr. Ooi touched on a lot of these in his talk. So we know that there's the general ones of reducing your mortality, improving clinical outcomes such as improving your blood pressure and cholesterol, but also strengthening your adherence to medication, which is where his app is also fantastic because it further instills that, that adherence. But one of the biggest benefits for me is seeing them get back to their normal activities that they didn't think they would be able to. And from a patient's perspective, and it's not written on there, but whenever I ask my patients, what have you found to be the biggest benefit of participating in a cardiac rehab program? Majority of the answers are they got a lot out of going through the program with people that are in the exact same position as them. They've had a surgery, they've not had much preparation for that surgery, and they're trying to wrap their head around it, trying to figure out whether what they're feeling is normal. For me, all I can tell them is, I've been doing this for 9 years, what you're telling me sounds right, and the textbooks back that up. And they get comfort out of that, but they get even more comfort out of knowing that somebody else, when they're saying, I'm often a bit puffed, even when I just get up or move around, someone next to them who's been through something similar will say, yeah, that's what I went through, but now that I'm a little bit further down the track and I've been doing some more movements, I don't have that anymore. So just that camaraderie and that togetherness of knowing that, you know, it's someone actually understands 100% what they're going through. And from a health perspective, in terms of the burden on the health on hospitals, we know that participation in a cardiac rehab program can reduce hospital readmissions within the first year of a coronary event by 56%. And it also reduces the risk of the incidence of death within the first year by 30%. And they're massive, massive things. So there's a lot of benefit in that participation. So I'll just quickly go through who's suitable, because some of you might have an idea of a patient that might benefit from it. So I'll just have a look at who's suitable, what sort of fitness testing they might be in for, because a lot of them are terrified that you're going to make them do a stress test again. And then just what the recommended fitness guidelines are, as well as where they've come from, the research behind them. So this is just a general guideline of who's suitable for participating in a cardiac rehab program. And I look after, I've never had someone with a heart transplant, but I've had people with all of these conditions come through our cardiac rehab program and have really good results. In terms of who isn't appropriate for a cardiac rehab program, anyone with, just to name a few, unstable angina, decompensated heart failure, and severe or obstructive aortic stenosis. All of these we know are contraindicated with exercise, so they're better to be medically managed in other ways. So in terms of what fitness testing, we like to have measures to see what sort of improvement we're getting. We use a 6-minute walk test. It's a really simple fitness test, 6 minutes of walking at their own pace. And we look at how far they go, how many rest breaks they took, whether they had any chest pains or tightness. And we also monitor what their perceived intensity was while they were doing their walk. And what I've put up on the screen here is just a collation of the walking test results that I've collected over the last 5 or so years, and broken it down into what procedure they had done. And what you can see is that all of these patients saw an improvement of about 15 to 20%. And that has a really positive impact on not only the walking test results, but that translates into being able to be functional at home, getting back to work, and resuming their regular fitness program that they might have been doing beforehand. So all of our guidelines, so we use the National Heart Foundation guidelines to teach our patients what would be ideal for them to be doing. But when I ask them how much exercise have they been doing, or even if I was to ask you, how much exercise do you do throughout the week? Are you doing 30 to 40 minutes of exercise 5 to 7 days per week? When I ask this in a forum where I can see hands up, I usually only get 1 or 2 people saying that they're doing that level of exercise. So giving this sort of information to a cardiac patient is really daunting and really confronting for them, because they probably haven't been doing that even before they've had their surgery. And the idea of doing that now that they have had a surgery and they've got a diagnosis, that really is very daunting and confronting for them. So what we want to try and do is get across the idea of moving more and sitting less. So ideally, we want to try and change the way initially people think about physical activity or exercise. So basically, physical activity is anything above resting. So if you're sitting on a chair right now, you're not being physically active. If you stand up and walk around your room, you're being physically active. If you go to the shops and you do your grocery shop and you've walked around the shops for 30 minutes, congratulations, you've done 30 minutes of exercise. And whilst that's a really simplified version of what we're trying to get across, it's a really non-threatening way of encouraging people to be physically active or to become physically active. And it doesn't have to be big blocks. It can be small blocks. If you've never done 40 minutes of a block of exercise in your life, then I probably, even if you didn't have a heart condition, I wouldn't start you there. I'd say, let's start with 5 minutes of walking and see if we can do that twice a day and see where we go from there. In terms of the type of exercise, from a fitness perspective, different health conditions have been really strongly researched, including the cardiac side of things. And usually we come up with a gold standard of a form of exercise that's the best for treating that particular condition. So for example, for diabetes, the gold standard is resistance training, because it really helps. It's the thing that significantly helps manage blood sugar levels. But for the heart side of things, we see that aerobic exercise is beneficial, resistance exercise is beneficial, but there's no one that's better than the other. If you can be doing a combination, that's excellent. But if walking is your thing, walking is beneficial and it's going to give you the results that we're looking for to optimize heart health. And just to further back up what the Heart Foundation says, this is just a quick summary, procedure by procedure, of what the recommendations are based on research. Ignore the fact that it says barrier above the middle column. Think of it more as an intervention. So you'll see that for stable angina, for stenting and TAVI, the recommendations for the intervention are aerobic training, range of motion, and light resistance. Same thing for heart attacks, same thing for bypass, valve repairs, and valve replacement. The things that we want to make sure that we're doing is monitoring the signs and symptoms of any cardiac issues while they are exercising. And particularly for bypass patients, we've got those sternal precautions that the doctor mentioned before, where if they have gone straight through the sternum, we've got lifting restrictions, which I'll talk about in a moment. But we've also got the side effects of shortness of breath and probably some muscular chest pain whenever they're doing lifting exercises that we have to monitor. And then same thing with the insertion of pacemakers and compensated heart failure. All of them recommend the same thing, which is a combination of aerobic and resistance exercises. But obviously, as you can see in the pacemaker, the implantable devices, once again, we've got considerations of making sure that we're not doing any strenuous arm or lifting exercises too soon so that we prevent any dislodging of leads. So just as a quick recap of what is aerobic exercise. Aerobic exercise is any exercise that involves large muscle groups being used in a rhythmic nature over a long period of time. So walking, cycling, swimming, running, they're all versions of aerobic exercise. And they're generally things that you can do every single day without pulling up too sore or it's only if you increase your the amount of exercise that you're doing too quickly that you tend to pull up sore from that. But it's also generally the more inexpensive version because you don't really need any equipment to do that. Whereas resistance training, which is aiming to improve the strength of the muscles by exerting those muscles to a force greater than what they normally would be exposed to, that requires equipment. For our cardiac patients, we use two types of equipment. One is free weights. The other is TheraBand. I'm not sure if any of you know what TheraBand is, but it's a resistance band. And the different colors of the bands denote the different resistance of each of that band. So it starts light from yellow, red, green, blue, black, all the way up to silver, if we're really looking to give you a challenge. And we provide our patients with those TheraBands. We look at what their lifting restrictions are, if they have any, or we just look at what they're actually physically capable of doing while they're performing their exercises with those bands. And we give that band for them to keep. And then as they get stronger, we give them the next one up so that they can be doing their exercises at home and not needing to expend any money. When it comes to using free weights, I usually tend to use my free weights with patients that have lifting restrictions. So if a patient has had a CABG, they have been told not to lift more than 2 kilos, I like to give them the 2 1 kilo hand weights so that they know that I know that they've got a restriction, but it's also so that, and they can see that I'm sticking to that, but also it's to show them that this is the weight that you can do stuff with, and you can do these sorts of things at home. So think about what might be a similar sort of weight at home in a cleaning task that you might be wanting to do, but you're not quite sure whether you should or not. So it starts to I try and make things transferable into daily activities that they might be wanting to get back to. We're always monitoring the intensity of the patients, how hard they feel like they're working. We are always monitoring their blood pressure. We do that before and after their exercises, their exercise session, but we're also monitoring their heart rate. But often if a patient's on beta blockers or another medication that is limiting their heart rate response, we can't rely on that to be an indicator of their exercise intensity. So what we use is a rating of perceived exertion on a scale of 1 to 10, with 1 being you've just sort of stood up and there's a slight change in your breathing, to 10, which is you're gasping for breath, you couldn't possibly do a second more exercise. Where do you think your breathing is sitting on that scale? Because if your breathing rate has increased, it's usually in direct correlation to how hard you're working. And we like them to be between 2 and 4 so that they're noticeably puffing. They should be able to hold a conversation with you, but they shouldn't be gasping for breath. So I also do a talk test. I love talking, as you may have figured out. So I'm always talking to my patients while they're exercising, and that's just another way for me to see how they're actually coping. As I've been talking about, there's lots of considerations when we're exercising patients. The sternal precautions I've been talking about with the lifting restrictions. We're monitoring their blood pressure to try and get patients to understand what is normal for them, what are the changes that we're seeing, and we keep a track of their blood pressure readings, and if they're going to see their doctor or their cardiologist, we give them a copy of it so that they can help make good decisions about their medications as well. Another thing I just want to make note of is when it comes to hydrotherapy or getting back to the pool, we just like to let people know that if a person's up to their neck in water or up to their chest in water, the hydrostatic pressure on your chest increases the internal pressure in the chest cavity. So it can just mean that the water exercises can be a bit uncomfortable. And then just quickly, recovery expectations are really important, because if you tell a patient that they should be back to doing something too soon and they're not there, they start to think that they've done something wrong or that they're failing in their recovery. So these are not determined by me. They're usually determined by either the cardiologist, the surgeon, or you as their GP. So these are just some simple guidelines that we work off. So in terms of getting back to work, activities of daily living and exercise, we use METs, so a metabolic equivalent over time. So 1 MET is the amount of energy expenditure your body needs to function at rest. So 3 METs is 3 times resting. So if you can do a moderate intensity of exercise, usually we use that, we gauge that by walking up 2 flights of stairs. If you can do that without any cardiac symptoms or significant shortness of breath, then you should be able to return to most sedentary work and some general self-care and general housework. Anything above that, so if you can walk up 4 flights of stairs, you should be able to return to most gentle exercises. And then return to driving, once again, that's determined by the doctors, you as their doctors, and it can range anywhere between 2 to 6 months. And it all is also dependent on whether it's a private or commercial license. Lastly, I was asked to just comment on how COVID-19 has affected cardiac rehab. So for us, our outpatient program was shut down. So we weren't able to provide phase 2 or 3 cardiac rehab. Surgeries, non-elective surgeries were obviously still going. So it meant that patients that had any sort of heart surgery were getting phase 1 of the cardiac rehab and then nothing else, unless they had the amazing app that Dr. Ooi has developed, in which case they could have that care at home and that monitoring at home. But for a lot of patients, they may not have had that exposure to the support, the guidance and the education that they would have needed to look after themselves and start to integrate back into their normal daily lives. Social distancing just meant that we were limited in the number of participants we could have in our program, which just meant that there was bigger waiting lists for our patients as well. So even if they were able to get into the phase 2, it was a lot further down the track than we normally would have. Masks just made it harder for our patients to exercise. A lot of our patients experienced shortness of breath, particularly after a CABG surgery. So they found it quite difficult to exercise with a mask on. Our cleaning didn't change much. In a hospital, we clean a lot between every single patient. And equipment sharing was made easier because we had less patient numbers. But the biggest thing was just patient uncertainty. In a time when we're being told to stay at home and don't go anywhere unnecessary, particularly as a high-risk patient, the idea of coming to a cardiac rehab program in a hospital was really daunting for a lot of people, and that stopped them from participating in the program. Thank you for listening, everybody.
Thank you, Penny. That's very informative. We do have one question for you.
Yep.
Not all private hospitals have post-medical or surgical event cardiac rehabs available,
Yep.
Increasing the wait list and burden on public hospitals. Are cardiac rehab covered by private insurance and if organised by the EP in community medical?
From what I understand, it is. I'm not sure of the ins and outs of the health fund side of things, but I definitely know that it is covered from a private perspective. I'm not sure how it works in terms of referring via like an EPC referral, because there's only 5 visits that you can do, and that wouldn't be long enough for a cardiac rehab program. But as far as I know, it is offered and it can be accessed.
Okay, thank you. Are there any other questions? Oh, what is the benefit of hydrotherapy in cardiac rehab?
Yeah, so hydrotherapy would be something that you would recommend later, because a lot of patients have either sternal precautions or they're just their body is still recovering and it would be too soon to get into a pool. But from a lot of people find that it's really beneficial in terms of it's a gentler form of exercise. So doing exercise on land, usually I'm limited not so much by someone's cardiac issues in the cardiac program, which sounds weird. I'm usually limited by their joint issues. So often it's knee pain, back pain, and that sort of thing that's slowing my patients down. And so being able to, I'm here trying to encourage regular exercise. And if the regular walking is flaring up their knees, they're not going to want to keep walking. So being able to encourage hydrotherapy when it's available is a really good way for patients to not only get the aerobic and the resistance training that you can do in a pool, but you're helping to make sure that we're not flaring up or aggravating any other joint issues.
Penny, in just regard to the previous question, where we were talking about an EPC, the doctor has asked not EPC, just direct referrals for cardiac rehab. Is it covered by private funds?
Yes. Yes. So all you need to do, if you're wanting to refer to a private, to either a private cardiac rehab program in a hospital or anywhere, all you need to do is write a referral, make sure that it's got your GP details on it, like your provider number, and just what the patient is being recommended for, whether it's a preventative thing or whether it's post-surgery. As long as they've got that referral, they will be fine to get into a cardiac rehab program.
Okay, it seems we've come to the end of the session. So I would like to thank all of our speakers for taking the time to present tonight, and thank you to everyone for attending. Just a reminder to please complete the evaluation survey that will shortly pop up on your screen, and please visit our website to register for more upcoming webinars, including our next Prince of Wales private event, Bone and Joint Health, Adult and Paediatric Sports Medicine, and Arthritis Musculoskeletal Imaging on Wednesday the 7th of April. So that's it from us tonight. Thank you very much for attending, and have a good evening, everyone. Good night.